I'm going to show you some clinical biomechanical tips together with the invisible braces. It's going to be a clinical lecture, so you're going to see a lot of slides, a lot of patients, and some biomechanical tricks. So I work in Milan. I've been there since 2008, and I practice mainly lingual, and now recently I started some aligner cases. But still, most of the patients, they come to see me for lingual. Yeah, so I am like a specialist for lingual appliances. Yeah. In 2015, so about 10 years ago, I started as well to work in England. So now I've got like 10 years of experience as well there, which is also, quite rewarding, I believe. Right, so I'm going to speak about some biomechanics you can basically perform in your clinic. Yeah? So it's in-office devices. I like to bend wires, so I like to do most of the stuff myself. And we will talk about impacted or ectopic canine. So what can we do with the use of THY? We will see as well some asymmetric expansions or even compression of the arch. And THY, I think, are a great help nowadays because these asymmetric mechanics, we know they are always difficult. So without the THY, it would be rather difficult, if not impossible. Yeah. Then after that, I'll talk about some incisor movements. Yeah, so Ravi already showed beautiful cases and beautiful biomechanics like total arch distalization, anterior intrusion, and we will see as well from the inside how to do with this palatal THY, but not only. Sometimes we will use even retromolar implants. And I will conclude with the class 2 management. Yes, I will show you what we can achieve with simple mechanics, as I said, done in the office. Yeah, so I'm a clinician, I'm just sitting every day in the clinic, working hard. And I like, to have some tools or devices that can help me in my daily routine. So most of the times, I'm honest. I'm even not using the lab. I'm doing everything myself. So basically, my major tools will be some mini implants, lingual braces. Yeah, this is my favorite job. But recently we started as well working with the aligners. So I can see the number of aligner cases is increasing every year, but I'm very kind of selective with the aligner treatments. Yeah, so I offer them only if I know I can get to a good result. Yeah, Ravi already mentioned some minutes ago the mini implants. These are by Forestaden. Those are the ones I'm using, and they're called ԴIธ์. Yeah, so you see they added some new lengths, even some new designs. So especially for the palatal ones, they added some different lengths, a new neck, and as well, the diameter. Yeah, so nowadays you can get up to 2.3 millimeters, which is good because then you see you can use them in different areas. Yeah, Ravi talked about the intrazygomatic crest. You can use them in the buccal shelf. So you can use in the retromolar area, as we will see in a few minutes. So it's up to you, you just pick up some lengths you prefer. I remember I always like to use the 8 millimeter length, but today you can see we can use 10 millimeters, 12, even up to 14 millimeters in some cases. Yeah, so you can be very, very selective when choosing, the best length, the best diameter of those mini implants. And you can see now these new designs are quite good, with this long neck and quite large diameter for could be the buccal shelf or even the infrazygomatic crest. Yeah, so this I do a lot of times in my clinic. I do hybrid treatments, meaning patients come for invisible. I have to be honest, aligners are not invisible, they're transparent. But having said that, some of them will have maybe aligners in one arch and lingual in the other arch. So I'm doing these hybrid braces a lot. It's normally lower lingual because I get more leveling of the KHÅNG, and the upper is going to be aligners. So this is called hybrid. It's actually a good approach because you can, first of all, treat easily some malocclusions. Like for example, the class 2 division 2, we all know if you do upper lingual braces, it's really difficult, when you have a deep overbite, retroclined upper incisors, you need to change, the torque of these incisors, but the trouble would be the lower incisors will bite on the upper lingual braces. So this is why in a case like this, aligners are actually very indicated. So they can be an excellent indication. Just keep in mind, and I'm honest with the patients, I will tell the patients, I cannot really torque these teeth. They will just tip, they will flare out, but sometimes, tipping clinically can be actually aesthetically acceptable. So it's actually quite positive to see. So during those 2 days we have been hearing this a lot, all the limitations you can get with the aligners in terms of severe rotations and severe tippings, severe tip bites, the torque is number one problem with the aligners. Uprighting over canine, uprighting over molar can be really challenging with the aligners. So for these reasons, I can do this hybrid treatment, or I can even do the combo, the combination. So for example, you start a very crowded case, Of course you can do the whole case with the aligners from A to Z, but it might take ages, like 70 aligners, 80 aligners. On the other hand, if you do this type of combination, you start with the lingual braces, 4 months or 5 months, your liner level, you will be very quick, then you scan the patient, and after that you can finish it up with the aligners. So it's a way to really save a lot of clinical time and try to reduce the overall number of aligners that will be needed for this particular treatment. So these are some of the advantages, of the hybrid treatment. I would say definitely it's faster, it's more accurate, because anytime you use braces, it's going to be more accurate, and I would say it's still invisible. I can still offer my patients an invisible or transparent option, and yet, being biomechanically efficient. So let's start with the first topic, which is the management of ectopic and impacted canines with the THÜYs. And I'm going to start with this gentleman here. So he was tendency for a class. Nice working. So basically, he was biting forward in a full class 3 relationship. So this is actually, in a retruded position, a relaxed position, okay? But otherwise, the person was sliding totally forward in a class 3. The funny thing was, he went to see another orthodontist, and the orthodontist said, oh my God, you need maxillofacial surgery. The guy said, I'm not having surgery. You saw the profile. The profile is fine, it's not a surgical case. So basically here, what we have to do is to do a camouflage. We push the upper incisors forward, we try to retrocline the lowers, and by doing that, we will correct the class 3 kind of tendency, but it's not a skeletal problem, it's more like a positional class 3. On top of this, we have another problem, which is an impacted canine. So when we look at the radiograph, I will show you. Plus some crossbite tendencies. We have basically bilaterally, so you can see here and on the other side we have a crossbite, we have another crossbite on that side, plus the anterior crossbite. And there is another problem with this implant. Unfortunately, he waited too long to get the crown on the implant, and the molar unfortunately tipped forward. So I have to reopen up this gap, which is not a good idea considering, yeah, you can see it there. So considering that we have this class 3 malocclusion. Yeah, so basically what I'm going to do is this: I'm going to push the upper anteriors forward to jump the bite, but at the same time I have to manage this impacted canine. Yeah, so this is the lateral caffeine maximum intake patient. Yeah, so the patient is sliding in a class 3 relationship. When we look at the OPG, yeah, you now see the impacted canine, you see the implant, you see the tipping of this molar. So here is just tipping, which means I can use a push coil. It's not uprighting, which is needed, you know. Roots are okay, I just have to reopen up the gap because this is too close to the head of the implant, and then a push coil will do the job. Yeah, so fine for the push coil. Right, so the patient wanted invisible. I will start managing the impacted canine. Yeah, this is the baby tooth. Of course, the baby tooth has to go, so we will extract the baby tooth. And now you see this is the impacted canine, which is a little bit oblique here, so slightly horizontal, very, very close to the root of the lateral incisor. So first thing, I have to move this crown away from the lateral, which means I can tip the crown down and a little bit distally from the root of the lateral. How do we do it? Well, we don't have much anchorage. So if we look at this patient, I have a premolar with the root canal treatment. I have, I think, another molar. It's a couple of teeth, you know, it's not many. So I can use the ŁIธ์mini implants, yeah, or another mini implant. In this particular case, I use the 8 millimeter length, which was placed right, you see, vertically and parallel to the root canal treated premolar. Yeah, so this is the premolar, this is my anchorage, and then I can start loading the mini implant like this with the cantilever. Yeah, Professor Nanda gave a beautiful lecture on different types of cantilevers. So cantilevers are a single wire coming from a tube, or in this case coming from the head of the mini implant, and this will do this job. Yeah, it's basically extruding the tooth and moving the tooth away from the lateral incisor. That's all. So very, very simple biomechanics. You see, it's a single force, of course. And how about the magnitude? Very little, 10 grams, you know, 15 grams. We are just using our anchorage to extrude the tooth with a very little force. And you see the tooth is coming, of course, down bit by bit. It took a few months. So see, we are here, so I just have to tip the tooth more down, away from the lateral, and then it's going to be time to finally align it with the adjacent teeth. In the meantime, I'm using push coils to jump the bite. Yes, so I am proclining the upper anteriors while the canine will be moved more distally and more palatally. So here we are. You see the canine now is actually coming. We still need a bit more of extrusion. So I continued working with the TMA cantilever, but then at this point I thought I literally need, you know, some lingual extrusion. Yeah, tipping, lingual tipping and extrusion. And I thought, you know what, the best would be to do just a piggyback here. So double arch technique. So we have one anchorage wire still with the push coils, a 9 dissectional, and this was a great test, like we do for labial. It's just the same as for labial technique. So this was extremely helpful to have the canine within the arch, push it forward with the long push coil, but careful, you know. Anytime we use push coils, check radiographically they will tip the teeth, and indeed, I took a radiograph and I saw I needed a little bit of upright. But here we are. Now, it's a class 1, so the patient, is solidly in a class 1 relationship, positive overbite and overjet. You see, talking to his dentist, we needed a little bit of mesial uprighting of this canine root. So, once again, Professor Nanda, Professor Meltzer, double can deliver system. One can deliver on my canine, the other can deliver on the premolar. So basically, this can deliver, goes down here, the other one the same, it goes down there, so it's like an X, like a cross. It's an X, so the canine will receive some mesial root upright. This is a fantastic system. I remember when I started many years ago from Professor Nanda and Meltzer, I was amazed. I've tried it a lot and it's really working well. Here we go. So now we've got enough space for implants or removable prosthesis, and the patient is ready for the depot. So these are the final photos. The bite is acceptable. Unfortunately, oral hygiene is not. Yeah, this is just after the clean or during the clean, and you see he has got just a removable prosthesis or maintainer, but otherwise is in a solid class 1 relationship. Yeah, so this is now the gap left for some implantological work, and now with the prosthesis. So if we look at the pre and post, yeah, this is the patient before after treatment, the profile when smiling, the smile, and you can see it's quite a good change. And if you consider, the first orthodontist who saw the patient wanted to do maxillofacial surgery, yeah? So we did it just with the camouflage, and I think overall it's quite a good result, yeah, apart from the oral hygiene. So simple mechanics and yet quite a good result. This is another one, very simple mechanics. The guy said, I had a previous treatment, I don't know why they left this canine up there. Well, maybe it was ankylotic, or maybe they thought it was ankylotic. So it's up here, and he has got like a space maintainer. But look at this. I told the patient, this will never erupt spontaneously because it's blocked by this kind of bridge. Yeah. You see that? It's so stiff. Yeah, and imagine the patient was left like this after a previous orthodontic treatment. Yeah, crazy, huh? Right, so I said, well, we can try. I cannot promise you the tooth is going to move, but if we don't try, we will never know. So I needed anchorage as well here. So while I was doing my initial alignment and leveling, you see, first of all, I removed that ugly space maintainer. I left the patient with an FRC. This is a fiber reinforced composite. Here we go. And I do this myself. I even don't charge the patient because for me this is ugly. Yeah, I'm not Michelangelo or Giotto. So I just do something which is, okay. But this could be anchorage for me. It's still aesthetically pleasing for the patient, and I can even start, pulling the canine down. But you see, I left space between my FRC and the tooth. Otherwise, how do I move the tooth down if there is not enough space? Yeah? So this is how we started. You see, simply with 2 buttons, power chains. So imagine it's like a single force. And of course, you can use a palatal implant. This is again ortho-easy 8 millimeters. So imagine the power chain comes from the canine and it goes to this palatal mini implant. Yeah, very, very simple mechanics. The trouble is, when you use a power chain like that, you have to see the patient every 2 weeks. That's the trouble, yeah? So you have to monitor and renew the power chain, otherwise it will be passive. So Every appointment, you see, I was grinding down the FRC to allow the eruption of the canine. I was monitoring, you know, the smile, the anterior occlusal plane. You have to monitor this because otherwise you can get, you know, some count of the anterior occlusal plane. So see, I was grinding the FRC off and pulling the canine down. So I said, it's moving. I can see the tooth is moving, you know? But I came to the point that I was not really happy with this mechanic, so I said, you know, I better have like a cantilever to move it correctly. Here we go. So once again, TMA 1725 or 1825 cantilever. This is like an arm. Yeah? You can move the tooth the way you want. So you can move the way, for example, lingually, palatally, get some extrusion, lingual tipping. It's still a single force at the level of the canine, but you can activate it really according to your needs. Yeah, so see, this is actually what I'm trying to do at the moment. Bit of extrusion, a little bit of lingual tipping, so to say, of the crown, and it worked really well. Yeah, so still with the tat, so I'm not disturbing the dentition of the patient. It's coming, yeah, it's pretty much there. So at the end I had to close some gaps with the publisher. It was only one arch treatment, only the upper arch, so it's a compromise. Every time you have to treat one arch, and this is the patient at the end. I think quite a fair result. Yeah, the tooth is nicely there, it's a very good smile. Overall bite is reasonable. You know, again, I can't do any finishing with the single arch treatment, but otherwise I think it's quite a fair result. Final radiograph before and after, and you see all the comparisons before and after treatment. Simple, yeah, very short time. It was overall something like 10 months, not that long. Right, now, some small clinical tips. You know, many times you have asymmetries. Cross bites, scissor bites, it could be even in the same patient, like this guy here. So how can we manage simultaneously a cross bite and a scissor bite in the same patient? Well, I use this expansion compression technique a lot. Yeah? Yesterday there were a lot of talks on the MARPI, the maxillary expansion and so on. I have to be honest, I work a lot in the mandible too, yeah, so not just the top. I really try to work in the lower arch, which means, you know, sometimes I expand the mandible, sometimes I compress it. And there are beautiful articles by Professor Wichmann onto this. He published at least 3-4 articles about, you know, expansion and compression of the two arches, especially when you're dealing with cross bites. Yeah, cross bites are very common in adults. Let's see this patient here. You see, yet on one side a cross bite. Yeah, the canine is in a cross bite, but if we look at the left side, there is a scissor bite. So cross bite here, scissor bite there. So what do we do if we want to make it quicker and we want to have some extra dental anchorage? Yeah? So see, it's a very deep over bite. This is the tooth, the premolar is in a scissor bite and extruded, and here the canine is in a cross bite. He's missing some posterior teeth as well. So see, it's a very funny arch form. Yeah, so what I want to do is expand the canine, lingually tip the premolar. I wanted to derotate it, I had to stop because there was a bit of initial gingival recession, so my periodontist said it's better not to fully derotate it. And basically, yeah, this was the biomechanics. Yeah, so after the bond up, I just used one palatally, only one. THY 8. So see, on this side, it's everything in the office. Yeah, so it's everything done by myself. So here we have an expansion loop. I just bent it at the chest side. It's a TMA 1725, expanding, the canine out of the crossbite. And on the other side, it's easier, just power checks, it's tipping. Okay? So you just tip the premolar, basically all the segment here towards the palatal side, but that could be some help to correct simultaneously the crossbite of the canine as well as this scissor bite we have mainly on the first premolar. It worked pretty well. You see the patient, this is during treatment, pretty much at the end. So the deep bite has been reduced, the canine is a nice position, and even the premolar, of course, with tipping, has improved a lot. Yeah, there was, of course, tipping here. I stopped the derotation because of this initial recession. So see, the periodontist said, it's not really a good idea to fully derotate the premolar because of this recession. Mainly the canine, I think, was really corrected easily with this approach. On the other hand, as I said, this premolar needed more derotation at the end. But yet, still you see a different arch form compared to the start of the treatment. Now, let's talk a little bit about the incisors. Ravi gave a beautiful lecture on the open bite. Let me show you, this patient is quite interesting. So this guy is a medical doctor. He works in Switzerland. Zurich, it's very near Milan. We can normally take the train. It's about 3 hours. So he works in Zurich. He comes to see me just taking the train. And he is also the general dentist in Italy. So he's got these very old crowns. He doesn't like them. I agree. The smile is not really attractive. So he will need some new upper crowns. And on top there is a malocclusion. It is a class 3. So it's a class 3 tendency with very crowded, rotating canines. There are even recessions there. You see the crowding. So imagine the moment I'm going to, he wants only lower arch treatment. The moment I'm going to align a level, you can imagine it's going to be class 3, 100%. If I don't extract one incisor or 2 premolars, it's going to be class 3 malocclusion. So he didn't want any extractions done, like most of the Italians. So we just did the IPR. Of course, I had to do quite an amount of IPR, but you see, canines are very tipped forward, there are recessions all over, so I have to be really gentle with the level of the force, right? Oral hygiene, as you see, it's not good, maybe because of the rotations of the canines. Right, so I started with the lingual, so just one arch, just the lower, night eye 012 to start with, even a push coil from the start to make space for the canine, and then I started some IPR. You see the biomechanics, so you have to play with the biomechanics. So for example, here I am de-rotating the canine. You see with these power chains doing this kind of job. They are called chicane elastics, like Formula 1. I used another one even on this side, to de-rotate the other canine. And now finally the canine brackets have been bonded with IPR, a bit of power chain to pull the lowers lingually. But of course this is the problem, they will level up, so the bite is opening up, they will procline, and then the patient will be in a significant or severe overbite. Class 3 tendency overbite. So what do we do? Of course the dentist said, don't worry, if you close me the bite a couple of millimeters, 1.5, 2 millimeters, it's fine. He will need longer clinical crowns at the top for the smile arc. So to improve the smile arc, he will make longer upper crowns. Fine. So I just need a little bit of extrusion. How to do the extrusion? Well, we thought about the tunnels again. So we placed very high tunnels, really up here. so he could pull down with elastic. So basically, he was doing the elastic traction like that, a triangle on this side, like this, another one there, and it worked really well, of course, for a short time. So you see that, the darts, of course, these elastics at the front, and I managed to come here. And the dentist said, it's fine, you know, so we can now move on with the final upper crowns. That's all, that's what I need. They're okay. You see, even recessions are not worsening, yeah, so they are rather stable after treatment. So I did bone innovation, placed the bone in retainer, and now you see the smile after the upper new crown. It's a totally different smile, although I don't really like them a lot as a shape, you know, they could be better. But overall, I think this is very obvious. So particularly, the dentist improved the smile arc at the top with longer clinical crowns and managed, you know, to close the bite that additional 1.5 millimeter. So this is before and after, and you see the improvement. This could have been a dramatic class 3 without extractions, and you see, I think it was overall a good compromise in terms of final result. 2 years later, it's still stable. The patient is still coming to see me once a year, and you can see it's still alright, apart from oral hygiene. But yeah, the bite is stable. Yeah? The bite is stable. Right, now what about the intrusion of the incisors? Yeah, Ravi showed beautiful mechanics. Let's see what we can do from the inside. Yeah, classical pre-implantological case. So the patient has a massive overjet. You see the teeth are very protruded, large overjet. She needs a lower full unit bridge. We have some periodontal disease, of course, but that's it. You know, I just have to treat the upper arch, retrocline, intrude the upper anteriors. This is the overjet. It's a massive overjet. Yeah, it's a removable prosthesis at the bottom, so she will need implants and a full unit bridge. And at the top, of course, again, she will need implants and crowns. So it's a multidisciplinary case. This is my job, really easy. Retraction and a little bit of intrusion. Yeah, that's all. The patient will have 3 implants on the left side, 1 implant on the right. I could use the implants for anchorage, that's fine, but we have to wait for the osseointegration. Yeah? On the other hand here, I wanted to be a little bit faster, so I didn't want to wait for the osseointegration. She lost all the lowers, all of them. They were extracted because look at this massive periapical inflammation. They were mobile like this, yeah, so they had to go. And the top, you see, no anchorage, no anchorage, no. This is not okay for anchorage. It's too mobile. Yeah, you can't pull against only one molar. So it's an indication, you know, for either implants or mini implants. At that time we did the conventional setup. Nowadays we do it digitally, so we save a lot of time. She started with the bone graft. So when you do bone graft, you have to wait 3 months. Yeah, so you wait 3 months for the healing of the bone graft. In the meantime, I could start myself with the brackets. So indirect bond up, night eye 012, very light forces. This is after a month of treatment, so already aligned and leveled. And then she went back to the implantologist. So she got 3 implants on the left, upper left quadrant, yeah, and we have to wait for the osseointegration. So next step will be 2 ortho-easy mini implants. Place them wherever you want, so anywhere. And you just pull, you see the upper unit from premolar with short power arms, short because we want intrusion and a little bit of retraction, tipping, yeah, lingual tipping. How do we check where we are? Aesthetically, radiographically, so take records. That's the only thing you can do. You see now, they look better. Look at the profile, you know, aesthetically she looks good. the teeth look pretty much like the setup. You see, your budget is reduced dramatically compared to the start. And you can take some radiographs or have some night eye coils instead of power chain, so you can see the line of force on the radiograph. This is how you have to do. You need records, yeah? So now she got implantology here. She will need another implant there, and of course implants in the mandible. So we still have a little bit to work, but she's doing pretty well, as you can see. So now the crowns are actually the implant is here. She will need the crown there. These are the new crowns posteriorly on the left, upper left quadrant, before and after. You see the lingual tipping and intrusion a bit. 3 crowns, space maintainer that I removed later on. I did a little bit of finishing, and then she was ready, you see, even to have the lower work done, the final implant there. 1 unit bridge, as you see, over the implants, and of course she has now some teeth where to bite. Yeah, so we came to this final upper arch. What about the smile? Beautiful. I mean, look at this smile arc. Perfect, you know, parallel to the lower lip. Look at the upper incisors. Emma, 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 Mama. You check, you know, the exposure of the upper teeth. Beautiful, brilliant, you know, simple, very simple mechanics. I haven't done much work here. To be honest, yet the result I think is good, you know, it's a beautiful smile arc. Very nice profile at the end, lips are competent, good protrusion of the upper incisors, so everything is fine. If you have, on the other end, the more needs to get lingual tipping, yeah, for example, this is a perio case, he was smoking 25 cigarettes a day. I mean, heavy smoker, deep bite, defects all over, extrusion of the incisors, yeah, you see that? And flaring, especially of the lateral. So, if you are in this situation, I remember Professor Nelson used to say you have to pull the teeth back within the bone. Yeah? So pull the teeth within the bone. How do we do it? Yeah, you can do it as well with the tabs. So here, you see after a very light start, this is night eye 010, very, look at the recession lingual, root exposure, very light forces, yeah? After that, we can start with the palatal, 2 palatal ortho-easy 8 millimeters, power chains, pull everything, you know, lingually, yeah? And basically this will retract and intrude to some extent the upper incisor. Yeah, now you see the lateral looks pretty good, yeah, after that. This is another short treatment. You can do this in 9-12 months, so very short treatment time. Before and after. Look at the lateral incisor, yeah, before and after. The smile, the deep bite has been reduced, as you see, and the improvement, I mean, defects are still there. This is just ortho, no periodontal management of the defect, 0. Only ortho because the patient is smoking. The periodontist gave up, he said, you know, there's no point. So only by orthodontic tooth movement we get some improvement, especially of this black triangle, yeah? Before and after. Now, let's talk, and now we come to the end here, we have another 11 minutes, a little bit about molar distalization or full arch distalization. And again, you know, there is Professor Gilmes. Benedict will show you amazing cases. You know, he has his own system, which is amazing to distalize molars, to mesialize molars, you know. You can do anything you want, you know, open bite treatment, canine management, and so on. I am doing simple things in my office. So I look at this article and I said, yeah, why not? I could use, you know, the retromolar area, which is a very simple area for myself. I agree with Professor Nanda. We have to extract the wisdom teeth, yeah? Otherwise, we cannot pull against the retromolar area. So, very class 2 patient, deep bite, massive deep bite. This is class 2 deep bite division 2. It's not an easy case, you see. So you know, the moment we align a level, the overjet will increase. It's going to be a massive overjet, 8-9 millimeters, and then how do we reduce this overjet? So we will need some kind of cuts somewhere in order to retract the whole arch. Massive class 2, yeah? Full unit class 2 deep bite. I think it was overall quite a good case, apart from the aesthetics of his teeth. Right, so we started with the always with the low arch level, aligner level, you know, level the curve of speed because it's a very deep overbite. We bond the top. You see, of course, with bite blocks, otherwise there's no way you can cement the upper braces. And now you see the bite is opening. We do have bite blocks though, but look at the overjet, massive. What do you do here? If the patient does not comply, he needs maxillofacial surgery, simple as that. You know, how do we do this? I'm not extracting. This is not the case for upper premolar extractions. It's not a good case for that. Yeah? So, very simple mechanics, if you can. Try to, yes, extract the wisdom teeth, place 2 mini implants in that area, 10 millimeters, now we can have 12 millimeters, yeah, even 12 millimeters. Very simple mechanics, pull with power chains. So it's a total retraction of the upper arch, and you decide how long the power chain will be, together with class 2 elastics. So the patient is wearing class 2 elastics from the upper canines to the lower second molars. Yeah, you need good cooperation with that, of course, good cooperation. And you can see already this side looks much better. Final result, I was really impressed by the cooperation because this is good, yeah. Teeth are not beautiful, but it's a good result, I think, yeah, and within a couple of years of treatment. So upper retromolar mini implants class 2 elastics. If you compare, you see the smile still, you know, it's not the best smile. The profile is still convex because no maxillofacial surgery was done, but otherwise this is quite a good change. Look vertically, massive change. Overjet, massive change, pretty good sagittal correction as well. Yeah, that's a big movement, I believe, before and after. Okay, and yes, maybe I want to show you another one, which is a bit more dramatic. Yeah, this one. This is funny because it's only aesthetic treatment. It's another huge overjet. So she said, I don't care about, you know, the perfection of the bite. I just want to reduce this without extractions. Without extractions. Yeah? How do I do it? Again, I have to extract the wisdom teeth. Yeah, you have to extract somewhere. Look at that. And then use the same mechanics. You see how proclaimed there? This is an extraction case. Or even you could consider some maxillofacial surgery. So it's the same mechanics. And you see the retromolar implants, power chain. So you do the whole total arch retraction plus class 2 elastics once again. And before and after, I mean, the smile is a bit gummier because of course they get a bit of extrusion while tipping, but this is quite an impressive change, yeah, before and after. Look at the bar. It's not perfect, eh? It's not perfect. She's still a little bit class 2, but even this change in the overjet, it's quite good, yeah, so nearly corrected. This is another good one. A patient who was treated many years before when she was a child, and again she had this relapse, so proclination of her upper incisors. It's a class 2 long face, as you see, huge overjet gummy smile, yeah, and you see open bite with an old bonded retainer. So of course you can think, shall we extract? Maybe. In this case you could extract two upper premolars to reduce the overjet, but we need to take records. So you take a radiograph and you say, Jesus, you know, I mean, you see, this is the old retainer. So I took a radiograph, and yes, apart, even here, you know, from this view already you see, yeah, here we go. So there is nothing up there. And then I looked at the OPG. Of course, I did also CBCT, but already from the OPG, it's enough to see that there is nothing, I mean, very little roots up here. Yeah, so what do we do? Probably 5-10 years ago, I wouldn't have started this. I remember when I talked to my British colleagues, they said, you're mental, you know, why do you start this case? Why? But just to show you what you could do. Of course, you cannot use aligners because they will have anyway some force on the uppers or upper anteriors. So this is what you can do, even buccally you could do the same. So just bond up to the gainer until leave the previous retainer. Keep the gainers there, so she can even then start with the class 2 elastic, don't touch the upper incisors. So I did most of the treatment like that. You see she was wearing class 2 elastics here from the gainers, and then you see already the bite has improved quite a lot, and then in the last 3 months of treatment, I bonded up the brackets on the incisors, just to do this. A few degrees, 5, 6 degrees maybe, not more. Yeah? So same mechanics, these are the 10 millimeter orthoici, yeah, with the total arch retraction. And you see now, finally, I have bonded in the last few months the 4 incisors just to do the final T. Of course, you have to monitor everything with the radiograph. So I remember every time I was taking the OPG, I was praying. God, I hope she still has got roots. I hope she's still got some roots up there. They're still alright. Much better now. So then after 3 months of bonding up the upper incisors, I had to stop. I didn't want to carry on, yeah? And it's still acceptable. It's not perfect, but it's still fine. Yeah, so she was finished like that. A little bit of gummy smile though, but much better, you see? The proclination has reduced. Bite is reasonable. It's still a bit class 2 as you see on this side, but reasonable. Otherwise, you see, fair enough. I mean, you don't want really to overload these upper incisors. Final radiograph, you see, of course, the resorption is still there, but stable. Yeah? Stable. You see, this is the last OPG end of the retreatment, and you can see the resorption, but it's pretty much as at the start. Before and after, you see the changes before and after. Yeah. And the 3 radiographs, I think those are interesting. Yeah? So the before and after treatment was about 12 months, very short. The start, and then during treatment, when I bonded, after I bonded the incisors, and then this is at the end. This is not big changes likely. Right, I have just last couple of minutes, so just quickly I'll show you the last case, which is a multidisciplinary treatment, class 2, very deep bite, and again, oral light is not the best. The tooth here is really dark. This also has got root canal treatment, so he will need some veneers or crown at the top. It's a large overjet with gums at the top, as you see. And I'm showing you this case mainly for this side, because you see, this is actually the class 2 side. It's a full unit class 2. So to show you how I did the distalization unilateral with the THY and an in-office distalizer. Yeah? initial X-ray. So I started again with the 2D. After the initial alignment, you see the patient is already wearing class 2 elastics. I send the patient to the prosthodontist to have some improvement of the upper anteriors. Even provisionals are fine. So we take all the possible records for that. And this is my friend Paolo doing provisionals. So it's composite. It's nothing more than composite after digital smile design. This is the planning. And then this is the composite after all. They look pretty good, although it's just the cheap composite. And I'm still working, you see, with the class 2 elastics. The patient has got buttons and is still wearing class 2 elastics. Then it's time for a distalizer. And honestly, if I have to use something simple, cheap in the clinic, I will have a labial button, sectional stainless steel 1925 with a push coil, and the same palatal. You see, very simple. This is done by everything by myself. I just bend the things at the chair. So one ortho easy palatally, one buccally, and of course, you have to extract this. This was extracted later on. It's working well. Even this thing is working well. I noticed some crossbite tendency, so I corrected the crossbite with the asymmetric TNA expansion loop as we saw it before. So see, it's correcting bit by bit. It's correct. We just need a little bit of seating. Now this is after the expansion. And here we go. So the patient then was ready for debond. Of course, still with the old provisionals. It's a fair result. Pretty good bite. Class 1 with a little bit gap there. So we will need now the finals. To finish off pretty well, but still you can see even aesthetically it looks much better after treatment. Overjet and deep bite reduced a lot. You can see that. Of course, it's time now for the finals at the top. So then Paolo, my friend Paolo, did the finals. And then I stopped. So basically 3 veneers, 1, 2, 3, and 2 crowns for central and lateral. And at that time we were taking impressions. Now it's all scans. So just using the scanner. And these are the 3 veneers and the 2 crowns. The cementation and then the final.
Và đây là cái kết quả cuối cùng sau khi có phục hình vĩnh viễn.
Right, so to finish this presentation,
bài báo cáo của tôi ngày hôm nay,
I would say that even in lingual cases, you can combine touch with some segmented approach. Cantilevers, for example, power arms, uprighting springs, torquing springs. So segmented, I think, is still a great help, even for lingual patients. And we saw, you see, the treatment of impacted canines. Power arms with cuts are very good for incisors, so for retraction, intrusion of the upper incisors, especially in adults, periodontally old patients. And then for class 2 malocclusions, bilateral, mono, unilateral, you can use some distalizers, or you can do it yourself, maybe with the retromolar implant, or maybe with the palatal implant, a sectional wire and a push coil. But please, as Professor Nanda said, choose the biomechanics according to each individual patient. Thank you so much for your kind attention and enjoy the conference.
Thank you very much for your interesting presentation. Now, on behalf of organizing committee, Dr. Chan will give a certificate for speaker.